All right, 5:15, we'll get started. Before we get started on our meeting, ask Darrell if he'll lead us in a word of prayer. Sure.
Let's pray. Our most gracious Heavenly Father, we are just so thankful for this day that you've given us. Thanks for the opportunity that we have to serve you and to serve the community here in Lincoln County. Pray, dear Father, that you would be with all of our employees, our staff, our physicians as we take care of patients here in the hospital, and we may provide the same quality care to them. Pray, dear Father, that you would be with this board as we meet tonight and discuss the operations of the system. And we just ask that you would help us to make wise decisions that will further the Lincoln County health system so that we can help more individuals in the community. Just again, thank you so much for the many blessings that you give us each and every day that we take for granted. And we ask that you would just continue to bless us. In Christ's name we pray. Amen.
Thank you, Darren. All right, we do have 4 out of 7 members present, so we do have a quorum. First item on the agenda is the consent agenda. Does anybody have anything they want to take out or talk about? If not, I'll entertain a motion that be approved. Motion's been made by Dr. Morrison, second by Dr. Edwards. Any discussion? All in favor say aye. Aye. Any opposed, no. Passes. Number 2, quality report.
First thing we'll talk about is the hospital report, patient satisfaction. You can see there on the inpatient report. I did put both slides on there. I wanted you to have monthly and quarterly this time. We do have a downward trend on the inpatient side. That's primarily due to a major drop in our scores when we had no visitation on the inpatient side. We saw a great problem with communication and patients getting the information that they needed. We are seeing that that's already increasing. Though we put some actions into place, we did reinstitute leader rounding to see every patient that's not on isolation every day and really talk about communication with them. And then we also have a patient satisfaction work group that's meeting every 2 weeks to look at initiatives and what our priorities are and make sure that we have good follow-up in those areas to continue to improve those scores. The good thing is that even though we've chosen to report patient satisfaction through this time, the first and second quarter data won't be used for value-based purchasing for us, so we kind of got a little reprieve there. For the emergency department on the next slide, I really want to brag on that. The reporting scores have really gone up. The number of surveys that they've gotten in are increasing as well with that. They're not great, they're not where we want them to be, but we are seeing a little increase there. So great job in the ER that even through this time that's been a real trial for them, they've been able to improve their satisfaction. And then on the next slide, the same thing for the outpatient department. Really have done a good job on their patient satisfaction there. For safety and falls, we did have a couple of falls in June on med-surg, but we're happy to report that there were no injuries there. We have joined the Tennessee Hospital Association Collaborative for falls. July is the data collection month, and in August we start getting into more actions for that. So we'll be doing that in collaboration with the Tennessee Hospital Association. We had no sentinel events or near misses in June. And for regulatory updates, we are still awaiting our lab regulatory visit with CAP. We expected it in February, and then guess what hit? COVID hit, and it's been delayed. Last we heard, we anticipate that they'll be starting surveys again in August. So anticipate them at this point, August to September timeframe. We are not due accreditation visits or certification visits from the Joint Commission until spring, early year of 2022. They could come, but we don't anticipate a scheduled visit until then. Next slide, our current TI projects we have going. We have completed the medication reconciliation project. Now, that doesn't mean that we're done looking at it. We'll still monitor it, taking issues and going through those as we have them. But for the most part, that process has gone really well. We've seen a great decrease in our errors that were based on, meta-reconciliation. So, great work by Carrie and her team on that, and, the pharmacy group has really been instrumental in that. We last month talked about Foley catheter removal and starting that protocol. That has gone well. We've seen a decrease already in our number of catheter days that we have, and looking at utilization. So did really good education with the nursing staff, talked to the medical staff, and we've seen a big decrease, and the use that we have has been appropriate. So really, really proud of that. That's a big change for a lot of people. So we are in the monitoring phase of that as well. And then Carrie had a really good work group on titratable meds and critical drips in the ICU. Did a lot of work on improving that process and ease of nursing staff to be able to safely and effectively deliver those drips that are critical to those patients in the ICU. For infection control, this data is a little bit delayed. The past few days since I put this report out, we've seen quite an increase in the number of positives, but at the time of the report, last week we had 13 tested positive in-house. We do continue our screening processes. We are still continuing with elective procedures at this point, and we're managing that well. Our PPE's not had any change. We are still able to get what we need to take care of our patients at this point. Visitation is limited. Outpatient diagnostics, so lab, X-ray, CT, those kinds of things, are no visitors, except for some OB ultrasounds. They are calling to allow one support person with those at times. Inpatient units, unless they are suspect COVID or confirmed, do get one visitor. OB gets 2 designated support persons. And then, of course, there's always exceptions for those at end of life, those that have some type of disability or another extenuating circumstance. So the screeners and the nursing staff know that if there's somebody that really needs a visitor, to give us a call, and we want to be able to accommodate that safely. Any questions for the hospital side before we go to Donaldson? For Donaldson, I think we all knew that we did have the state survey completed there, and we anticipate a resurvey. I anticipate that to be in the next couple of weeks. We are moving forward with the mandatory testing there at the care center, and I'm happy to report, somebody knock on some wood for me, that we remain at 0 residents and 0 healthcare workers at Donaldson who have tested positive. And that's with weekly reporting of staff there. I want to talk a little bit about visitation and quilts related to Donaldson. That's not in your packet. I believe at the last board meeting, it was asked that we bring a little bit more information on the quilts program, which is the quality improvement in long-term services and support. The easy way to put that is it's the value-based purchasing for the long-term care side. So we talk about that a lot for the inpatient side, but this is for the long-term care side. And it really is a combination of threshold measures, which are things like family satisfaction, staff satisfaction, patient satisfaction, and then quality, culture is on that threshold, and then quality measures like urinary tract infections and antipsychotic meds and pressure ulcers, staffing, those kinds of things. So Lucy has done an amazing job. She came in right off the bat, started looking at the quilts information, where we were last year, where we needed to go, and develop some actions to get our scores up on that. So she has already put into place 3 action items working on to get that score back up where we want it to be. And those are reducing antipsychotic usage, and then consistent staffing and quality of life, which will increase that patient satisfaction. So resident choices in bathing and their medication times, and so really taking more of that. You know, we put a patient in the hospital or in a long-term care center, and we tell them what time they're going to take their meds. We tell them what they're going to eat. A lot of that's taken away, so to give them more choices and increase their satisfaction there. To the patient at the care center, so we do have a soft plan, for lack of a better word, to open visitation there that meets the guidelines.
Where did you just interrupt you? Where's the guidelines coming from?
The Tennessee Department of Health. And I actually have a copy of those as well. The thing right now that's really holding us back is that the Department of Health lists several prerequisites that you have to have for visitation, and we meet all of them except for the disease burden in the community. So that has to be stable. You have to have less than or equal to an average of 10, a rate of 10, which is 10 cases per 100,000 persons over the last 14 days. So the Department of Health has a website. We pull that up. I look at it every single day. I report it to Daryl and the leadership team every day. And since about July 10th, we've been above that threshold of 10. As of today, we're at 21.2, and it continues to climb right now. So until we get back below that threshold, even though we meet the other prerequisites, we can't open the visitation up. I do have a meeting scheduled for this week with Lucy and Natalie, the administrator there, to make sure that as soon as we can open back up based on the rate for the county, that we have everything in order, ready to go, and looking at sending a letter to all the resident families so that they're aware of what that'll look like and what we're waiting on. At that point, I know that I can't imagine how hard it is, and it's been one of the harder things we've dealt with through this. It really has.
Let me ask a question. What was stopping us in like late June or mid-June when the rate was lower from allowing it if it was below 10?
A plan, a solid plan in place and staff to monitor. So when they come in, when they can't touch, it has to be a constant monitor, it has to be a scheduled visit, and then there's one of 3 ways that you can do it. So by the time we had a set plan in place and we're able to schedule those visits and start that, we started having our increase in the community.
Was there not about the time we could change in leadership?
There was a change in leadership about the same time.
On the survey, everything that we got dinged on, is that everything back good? You expect everything to be great when they come back?
Expect it to be when they come back. August 1st was the deadline to submit it. So anytime after August 1st, we expect them to come back. We did send in a plan of correction. They sent it back to us, and we had to make 2 small corrections as far as the wording they wanted. And so we did that, and so we're sitting on go, wait for the survey. And like Courtney said, Lucy has been out there for about 6 weeks now, and she's been working weekends. She's been there 8 to 9 at night. So she's really working really, really hard. So we expect everything to be good, John.
Good.
She got experience in nursing home.
Yes, she has over 10 years of experience in nursing
So
home.
that's good. We need to get somebody with experience.
Yes.
Natalie, the same way?
She has well over 20 years. She's an interim, and I'll talk more about her during my report, if that's okay.
Yeah.
But, yeah, she has probably 30 years of experience.
Any other questions, comments? All right. Home health and hospice. Is that just for information, somebody gonna go over it?
It is. Do you know anything about that? Okay, it's just information.
All right, we'll need to motion to approve quality report.
So moved.
Motion's been made by Jack, second by Dr. Morrison. Any discussion? All in favor say aye. Any opposed, no. The ayes have it. Chief of Staff, Dr. Klein.
We had a meeting last week, nobody killed each other, so it's a good thing.
Success.
And you've already approved all of our things submitted there. We're continuing on in our quality improvement measures, monitoring each other's things. So we go through our, what do we call that, FPP?
SPPE and
Yeah.
OPPE.
Yeah, but what's it stand for?
Focus Professional.
Focus
Practice
Professional, thank you.
in Illinois.
Right. We will continue to do that. Nobody showed any current problems. There was one issue that was brought up, and I talked with the ER senior physician there about making sure that we have proper turnover, so when a a patient is admitted between the hours of 3 and 7, when there's no doctor in-house, that the ER doctor calls whoever the attending is going to be to do a doctor-to-doctor turnover.
All right. Any other questions, comments, Dr. Klein? All right, we will move on to the senior administrative report, nursing.
Just to back up what Courtney said, we did have an updated visitation policy, and it has proven to be good, except for we have found that we have a lot of people in the building now. It went from nobody in the building to too many in the building. And so we did cut back on outpatients getting a chest x-ray or a lab, and asked that they not have a visitor. And that's actually helped, because it has cut down people in the waiting room. And we haven't had any really complaints about that so far. So everything seems to be going well right now with COVID-19 and visitation. The COVID-19 numbers that you see there, those are from Thursday, and of course I have to put those numbers in from last week because of the published date for BoardPAC. But as Courtney said, we're over at 21 per 100,000 in the community, which means it's rising. And so lots of COVID-19 going around. We've got a full ICU. We had 6 in the ICU this morning. So just lots of folks with the COVID-19. We're currently in the process of getting COVID testing in-house, which will be a tremendous help for us. And we are also, thanks to Dr. Klein, this afternoon, we're trying to get a machine for our care center. The care center has to test every week, and they have to test the employees every week. And then I think they have to routinely, not weekly, but on occasion, they'll have to test the patients as well. And so we are trying to get a little machine out there for them too. He had a run on a machine, so I called the rep this afternoon and asked if we could get that machine as well. So hopefully in the next 30 to 45 days, we'll be on go with that. We've discovered this week, and this literally changed in the last 10 days, where every psychiatric patient has to have 2 negatives before they can go to and be dispositioned. And so now that's starting to be a backup of psych patients in there.
What's the time difference?
Ronnie had one last week for about 6 days.
No, I mean the time
Between the two
difference
tests.
between the 2 tests.
Well, it depends on the day, because if they come in on a Monday or Tuesday, I can have it all back by Thursday morning.
No.
Hours.
Yeah, 24 hours in
Between
between
the actual
tests.
testing.
But if they come in on a Thursday, it could be a full 7 days before we can get everything back. So
Who's paying for that? As far as, are they gonna be inpatient?
Skin care, whoever their care.
I mean, they're gonna pay for that, just waiting on a COVID test, even if there's no medical reason to keep them here?
They can't be admitted though, it's just because
Say that again.
they can't be admitted.
So what are,
They don't need inpatient.
so what are they?
They're an ER patient
hold.
Oh,
for that long.
Okay, so for psychiatric,
where are they gonna stay?
I thought thought the psychiatric was supposed to go into the ICU for a one-to-one watch for safety.
No, it depends on what level they get assessed at. We have a really good assessment tool, and, you score them out, and if it scores low, then they don't have to be one-to-one. If they score moderate or high, they do. So it just depends on how violent they are, to be honest with you. And then we've had to do some finagling and some miracle work with all these psych patients, because at one point last week we had 5, and all of them were here for 3 to 6 days. I mean, it was just crazy. So we had 1 on med-surg with a 1-to-1. We had 2 in the ICU as a 1-to-2, and 2 in the ER as a 1-to-2. So it's been kind of crazy.
That's a mess,
It's a mess.
because you need your ICU beds for your truly sick people.
Right.
And you're blocking them with psych people.
Right. I talked to the senior team yesterday. Was it today or yesterday?
Today.
And told them that we may have to get creative and maybe do like a little psych unit.
Yeah.
It can't be an inpatient unit, it just have to be a holding area, but, someplace where we can safely put them, but get them out of the ER, because it really clogs things up in the ER when you've got lots of psych.
And who got to arbitrarily decide that they wanted 2 negative COVID? Is this
The receiving facility,
is that a one facility, or is it all of them?
they've all done it.
it's
Not
more
gonna be
common with your private insurance places, Moncus and then if they've been in we have had some, but it appears, and I've not spoken to them, it appears that that's more if they come, depending on the location they come to us from. So if they're in a communal environment, they definitely require at least one. In some places, you have to have them tested not only 24 hours apart, but they have to be tested within 72 hours of transfer. So if you can't get that result back timely too, then you're in double trouble.
Very
Yeah.
challenging, and that's gonna really affect our ER numbers next month. So when you see all the throughput, and the ER length of stays that have been drawn out, just be patient with us, because that really does affect those numbers. All right, so, in the process of getting in-house COVID testing, as Courtney said, we have been invited to participate in the THA's, fall reduction collaborative, and that's great. We will be doing that. And then Lucy, who has been, she has been great about wanting to learn and participate with, me and some initiatives that we've got going over here. So I'm very glad, I'm getting that kind of feedback from her. I'm excited about her being there. So she's gonna participate as well in the fall collaborative, and that will only help at the care center. I'm gonna skip the number 5, because Courtney's already talked about it. Number 6, still waiting on CAP. Probably the middle of August, and the care center is waiting on their state follow-up survey. And then 7th, we're gonna have some leadership changes. Samantha, Sims wants to step back from med-surg and just do case management. And, Jessica Bates is going to step out from doing the OR.
Okay, can you say that again? Slower.
Jessica Bates,
No, I mean the previous.
Samantha,
Samantha.
you know Samantha.
Yeah.
She's a chart Nazi that.
Yeah, AKA. So she's gonna do what?
She's just gonna do case management.
Okay, so she's been doing nursing and.
She's been doing med-surg.
She's been running med-surg.
I knew that.
And
Okay.
she did a great job running med-surg. Med-surg nurses really love her.
Okay.
But, she,
So now she's just gonna be case management. So we're gonna need a new med-surg. And who's it, do we know yet?
no, I'm interviewing right now.
Okay. And then Jessica's stepping away from surgery?
She is.
She's done an awesome job.
She has done an amazing job.
Just-
So, yeah, they'll be, both of them will be part of the great directors.
Is Jessica leaving the facility totally?
No, she'll, go and work someplace where she has
In the system?
a little bit less hours.
Okay.
And has,
She's going to work on them.
Oh, okay.
Now we're back.
Gotcha.
All right. Finance, is that all you?
I'm done.
All right, Bob?
Thank you, Mr. Chair. The first item is the scorecard. Again, top section showing the operational statistics for the month. And again, I'd have to say, we're making a little bit of progress in the outpatient arena, obviously from May, but we're still feeling the effects of COVID, obviously. The ER visits are just a smidge over 30 ADV. We were about 39 ADV before COVID hit. We are starting to see the month of July, though, it's been real heavy with this new onset of COVID, and there's a lot of activity going in the ER, so I expect July to be up a little bit. Outpatient visits continue to hold about 10% off pre-COVID. Deliveries were down a little bit in June, but I know Dr. Morrison made up for it in July. Been very active in July. EMS had an unusual...
She made it for last week.
That's right. EMS was down, and again, I think part of that's very seasonal, to be honest with you. In June, it's not very high typically, but then on top of that, our skills unit was down, and ICF trips to physicians and stuff were down as well, so that has an impact there. One thing I will comment about that kind of stands out to me is the surgery levels. They're very solid, basically coming back off of the first first wave of COVID, if you will, at 65 total cases, which is better than last year and just short of budget. About 40 of those were done by our 2 physicians that are employed by us, so they had good volumes for the month. And I wish Anthony was here to see the ER conversion rate. It's still hanging high at the 8% mark. And that is, again, just a common theme again. Throughout COVID, we have seen a lot of admissions coming through the ER, and so inpatient activity is actually up slightly.
Since he's not here, I'll say, it's still not that 13.
That's right. That's right. Let the minutes show that. All right, and then skip down to the financial performance there by the entities. Let me start off by saying that there's a lot of atypical items in the book. This is year-end in June. You've got a mixture of year-end inventory adjustments. You've got some year-end accounting corrections and adjustments that were posted. You've got some reserves that are made that are anticipated to hit in the next coming fiscal year. And then on top of that, also we posted some stimulus money that came in the door. So, obviously, there you see the surplus as a system. I think probably what's more pertinent is if I told you what would it be without all these unusual items. And that is that basically the system would have posted about a $310,000 loss. And that's actually a little bit better than where we've been running in the COVID months, but it's not far from it. It's about what we've been running the last several months. The hospital-based system would have lost about $4.25 for the month. So again, still suffering without getting those outpatient volumes back up. I didn't mention physical therapy, that's another area.
But we would have lost $425,000?
I'm sorry,
So we would have lost $425,000?
the hospital base.
Right.
Right, nursing home without.
Which is a big improvement over the $798 last year.
Well, that's true over last year, but again, last year.
Just complimenting you on good work.
Oh, well then, we'll just stop complimenting. So, the records show that, and we'll move on to the next phase.
Did you say that the outpatient was down still?
Still.
Is that due to scheduling, like people don't want to schedule tests, or is that kind of a deal? Because our physicians just not referring as much stuff over?
No, I think it's more the public perception.
Okay.
Still a little concerned about coming out and having elective type things.
Gotcha.
Right. So that's that on the finances. Let me skip down to just a couple of quick items. I've been kind of telling you all the last several months that we were going to change out our EMR in the physician world, and that is, as of today, go live with today. I didn't see any smoke rise over there or people leak from the second story, so I think it went okay. We're excited going to Athena. It's the industry leader as far as the physician EMRs, and the cost to us will be about half of what our current EMRs cost us. So it's a very cost-effective tool, very robust functionality-wise, and so I'm very excited about it, and I'm sure Nick will be when he gets through it this week, and it all goes good. But early reports are that it's gone very well. And I will say this, they were originally going to have on-site people, which is typical for a Go Live. But I got a call Thursday, and they asked would it be okay if they did it remotely. And so we went with that, knowing the situation. They were concerned about their installers being exposed wherever they go. And they rewarded us financially by waiving the install fee. So we're thankful for that as well. Blue Cross rates, I think I've been mentioning, we're just waiting on their contract. Again, that'd be a big boost for us. About a $400,000 impact. TennCare payments, we seem to kind of hit a hold pattern there now because basically of the COVID situation, it's our understanding that the state has basically said they don't want to make any changes at this time to TennCare rates. So that's still going to be a pending item for us to go after. I mentioned the physical inventory. We did receive about 2 months ago from the state a rural readiness grant $500,000. We had to submit data back to them by the end of July, to show where we spent the funds, and that has been completed and submitted. And then last but not least, it's my favorite time of year, I have the external auditors here, camping out for a month with me, so. Always a good time to finance.
Right, anybody got any questions, comments, verbal abuse for Bob? All right, CEO?
All righty. We've kind of talked about, the top two, but just to kind of recap the Donaldson Care Center Administrator update, we have Natalie Berkeley Brown, who's serving in that interim capacity, but I have hired a permanent replacement, a gentleman by the name of Jack Grove. Jack has been in Gulfport, Mississippi for the last 3 years, and interview with Carrie, Wendy, Courtney, and myself. I think he will bring to the table that stability, that leadership that we need out there. And so he will be starting August 24th, and he has a wife and 3 children, so he'll be relocating here. So looking forward to Jack being here. The Care Center Director of Nursing update, kind of talked about it. We interviewed several candidates. Lucy jumped in as the interim. Lucy James jumped in as the interim. And after we interviewed a couple of other candidates, just felt like that Lucy had the facility going in the right direction. So I took away the interim tag, and she's now the DON out there. And Jack has spoken to her, and so they've already kind of started communicating everything. So got that relationship going. Survey update, we talked about that a few minutes ago, sometime in August. We expect them to be back. In the Donaldson Care Center capital, we're in the process of getting, well, we purchased one air conditioning unit for our dietary department. I believe y'all approved that last month, or a month or 2 ago. That was approved. That we got the kind of, I guess air conditioning place that we over here. We got some of those scratch and dent units, but they're basically brand new. So that'll go in the dietary, and then also we're getting quotes for, we've had some issues with our air conditioning on a couple of the wings in one of the nursing stations. And so Randall and his men and I were out there, and we're getting quotes, and hopefully we'll be able to rectify that fairly soon. I have the quotes by the end of this week from Randall. And I think that'll go a long way to help with morale of employees out there, because it's hot in some of those areas and everything. Hospitalist update, as you are probably aware, Dr. Williams' last day is August 3rd. Dr. Thomas has been working on the schedule. So for the month of August and September, we have coverage. Dr. Edwards is helping out a couple weekends, I know, in August. I'm not sure about September yet. I haven't seen September schedule, so it's in place, but he's nodding yes, so I appreciate that. And then we're in the process of, Dr. Thomas and I have had a couple of phone interviews with some hospice candidates, and we had an on-site visit last Thursday with the candidate. And that individual will work a shift, will work a week in September for us. So it's physicians, I want your input, solicit that, see what you think about candidates that we bring in to work for us, that we're considering for permanent placement here. So I'm going to rely on y'all to help me with the potential list. So that's our hospital update. Item number 6, radiology of Huntsville. They served a termination notice to the last Thursday, so their last day as far as full-time coverage will be September 21st, and Dr. Lehman is retiring. So
that's kind of out of the blue, I believe, isn't it? Did we see that coming anywhere? Is that based on numbers? Later, okay.
And then, I'm working with them, Radiology of Huntsville, on a transition plan. It may be a couple options they've pitched to me. Then also I'm gonna look at some other surrounding hospitals, look at their radiology departments, and see if maybe some of the other hospital radiologists have an interest of coming to Fayetteville. So,
Where's Podorski from?
Murray.
Murray. Because he used to come down here and cover Dr. Lehman all the time. He was very interested.
Is that Greg?
Dr. Pod, I don't know what his first name is.
I thought he was Tullahoma, but you're saying he's from
High
Murray.
Dworsky's from there.
Item 7, Mayor Newman invited me to his press conference on July 14th, and basically, just spoke about our visitation policies as of July 13th. They may have changed since then, but, we did go over that. They haven't changed, have they?
I think that was right when we did the change.
That's right, when we did the
I don't
change.
think we've changed it since then.
So I appreciate him inviting me down to, speak and, tell the public and the community and the county about our visitation policy. Dr. Cox, our cardiologist, we've spoken about, that Russ had a big part in recruiting here, started July 8th, and he's here on, Wednesdays and Thursdays, half a day. So we expect our cardiology program to grow along with, working with they're not going to be working at it, but with Dr. Jackson being here also. And then number 9, their organizational chart update. I think that's on the next tab. Kind of want to go over that with you. After being here about a month and a half, let me get this open. Mine's not open. There it is. Mine's open. So what I've done is, you can see, we have myself reporting to you as the board, and then you can see underneath there the chief executive officer, the departments that report to me. So the ones in italic, if you can see those in italics, are the kind of switches that we've made from the previous organization chart. So Patrick, Rehab and Wellness Center, Justin, who was here last month, he'll be reporting to me along with Nick over the physician practices. And that the Dawson Care Center Administrator also reports to me. Under the Chief Financial Officer, Bob will be picking up IT and food and nutrition. Carrie, as the Director of Nursing, will have some dotted line responsibility with the Care Center, even though the Administrator of the Care Center will be over Lucy ultimately. We just need to have Carrie and Lucy work together a little bit more closely than maybe what has happened in the past. Under quality, Courtney is picking up compliance and the medical staff coordinator position. We'll be reporting to her. And Wendy, of course, will have employee human resources with benefits, payroll, employee recruitment. So those 5 individuals will report to me, and then the ones that I mentioned with italics have been kind of moved around. Some of them used to report directly to the CEO, and I just thought that I needed to, kind of change it up a little bit so that I can spend more time with physicians and the community and things of that nature. So, any questions about the organizational chart?
Well, I find it interesting that the physician secretary,
Medical staff coordinator.
medical staff coordinator now goes, of course, to nursing.
Where was the medical staff coordinator before?
Reporting to me.
To you directly.
But it's reporting now to quality. And
I know she dealt with a lot of quality reports, stuff like that.
I think she'll be a big asset to help Courtney and some other.
Y'all get along
She'll
well
assist,
forward.
she'll assist with, your SCP, OCP, that, it's not in doing quality reviews for them, but we have to work together with her very close to be able to get that and when it's due and what day was this one credentialed and privileged and, those kind of things anyway, so she already does a lot in the quality department.
You mentioned the unit, we purchased, I thought it was a scratch at the end. Does it still have a warranty the same as the
Yes.
new?
Yes.
Okay.
That's a good question. It does.
All right, does anybody else have any?
Well, I have a question. Donaldson Care Center Administrator will answer to you, that's understandable, that's the way it should be. But have you got a different organizational chart for the nursing home? It looks like to me the Director of Nursing at the Donaldson Care Center would answer to the Donaldson Care Center Administrator.
And they will, Jack. Right now, it's kind of a dotted line. It doesn't show as a dotted line on here.
Right.
But, until Jack gets here and we work together to develop his own organizational chart and hire people that have left positions there, they'll have their own organizational chart.
Yeah, I would think that Donaldson pretty much would be
He'll probably,
administrator under you, and then everybody under administrator, and then like Donaldson, the Director of Nursing, working with Gary, sharing information, same thing with quality, because hospital and nursing home different.
absolutely.
And,
We just want to be able to share information, be resources for each other,
Right.
work together.
and that's good, but we've had a lot of trouble in the past several years about hospital people trying to run the nursing home and don't have a clue what they're doing.
Right.
Of course, that's previous administration.
Sure.
We're getting that straight now.
Yeah. I think, yeah. When Jack gets here, he'll have his own organizational chart with quality, MPS coordinator, social worker. But, he'll ultimately report to me. And then, so you're correct in that.
Well, I just feel like we screwed up 3 or 4 years ago. Hopefully we'll try to get it. I mean, we took a lot of, nursing home kind of stood on its own, made $1 million a year.
Yes, sir.
Then we started fixing it apart, bringing our financial people from the nursing home over here.
Yeah, but the rules change.
I understand the room change, but all of a sudden, you had people that really don't, nursing home different from the hospital.
Yeah.
I'm not trying, it's just a lot different.
Oh, it's totally different.
And it's obvious when you look back at the numbers, it's hurt us. And now we've got a major problem with PR. And, looks like we're gonna have to hire Alex Trebek. But, we gotta get that fixed because we're getting beat up.
Well, I'll tell you, as I've told some other board members, I've spent a lot of time out there with Wendy, and there's some things that are some, I'll call it easy wins that we can do immediately before Jack gets here that will help with some of that situation.
I think we're headed in the right direction. I'm just, it's just,
Yeah.
we had some problems a few years back. We're working toward it. We've corrected some of those problems.
Right.
And we're headed in the right direction.
Good.
I think that's kind of why he wants to do that, just
Yeah.
make sure that train gets back on track and,
Yeah.
with Kerry there, it stays.
Right. And I think it's great to work together. And if this, Lucy's gonna go do the same thing with you like you talked about a while ago, I think that's great.
We're a system. We try to work together.
That's right.
Anything else on senior leadership report? All right, entertain a motion, we approve Dr. Klein and the senior administrator report.
Make a motion.
Motion's been made by Dr. Evers, second by Dr. Morrison. Any further discussion? All in favor say aye.
Aye.
Any opposed, no. Financial operations, Bob?
Yeah, actually, that's there just for information purposes. That's the full report that was given to the Finance Committee this past Thursday.
Is that the Julu report?
Do what?
Yeah. Did you,
Oh, yes. 61 pages of your reading pleasure.
All right. That's for information, human resources, that's for info, Donaldson Care report.
I
Anybody
think
going
we
over?
talked about that really with the quill, survey.
Therapy report and EMS, just for our reading pleasure.
Yes.
All right. Let's see, let's take all those in one swipe. C through G, financial operations down to EMS, we'll just approve those in one swipe. Need a motion by Dr. Morrison, second by Jack. Any discussion, all in favor say aye. Any opposed, no. New business. Any new business? Anything under other? Capital purchases?
Yes, Mr. Chairman, there's 2 items of capital that we would like to get the board to approve. One is a ventilator, obviously very pertinent these days. The current ventilator that we have has got a lot of age on it, and, obviously we deal with COVID, et cetera, that it makes sense that we have one that's new, functional all the time, very dependable.
So
Right
we're
now,
gonna add to this one, or replace?
we will add, this
So we'll
is
have two.
complementary, so we'll have two, and then, of course, we have a, portable one, is a third, but it's an obvious that we probably needed to have one anyways.
What's your, delivery date? Is it backed up?
That I don't know.
You know, the way things are, you might order it today, we might not get it in 2 months.
It's a very good question, and I'll need to follow up on that, Jack.
I mean,
Good question.
the way things are.
High demand for it. But we are looking to, seek your approval tonight on that. And the other item is an ultrasound unit, it's, again, above our threshold for approval. It's, $93,000. That's a refurb, I believe, right? Yeah.
Is it below budget?
It is low budget. Budget was actually, I think, 102
What
or
is it,
somewhere.
two
in
to
there.
four?
We budgeted 100, but the original quote was 110, so it's actually 1,700.
I didn't hear your
What's
question.
it for?
Ultrasound,
For?
What department?
general,
Just
general.
general?
Yeah.
Oh, for the hospital.
Right.
Radiology.
But it can also do, can it also do, the cardiology studies as a backup, I think. Echo.
That's what I was wondering, since we had Cox, is that what this is for?
The ventilator budgeted as well?
No.
You know what Anthony would say.
We
Where's
will-
that coming from?
Well, yeah.
What are we gonna give up?
To that answer, Mr. Chairman, we have not spent all of our dollars that we had allocated for the fiscal year that just ended. So we could substitute any of that and/or going forward, so it really could be either way.
We didn't have that much left over?
We do, we had like 67,000 left.
All right,
I
did a-
nominate to do that.
What's that?
We had it from
Spend last year's
year.
money.
That's the easy way.
Well, yeah.
All right, so then a motion.
Yes, sir.
Motion's been made to approve ultrasound and ventilator, capital purchase, seconded by Jack. Any further discussion? All in favor say aye. Any opposed, no. The ayes have it, and I believe we need an executive session.
Well, I just wanna know what happened with the air conditioning. Are we fixed up on Second? I mean, it's nice and cool up there, but I was up here the weekend, it wasn't.
We are not, we're filling it with,
A lot of Freon.
a lot of Freon. We're waiting for it to be cooler because we have to replace the compressor on that. That will take several days. So we have
We don't
opted,
need to have it running.
right, we opted to wait till it gets maybe a little cooler. And then we can take it down and replace the compressor.
But we're not gonna have to, how much is that gonna cost?
I want to say it's under $10,000.
Yeah, that's all right. 9, 10
Really?
for the investment.
Right there.
Have you write that down, Frank? I just did a compressor, my unit, it was 6,500.
Well, yeah,
Randall's is 9 to 10,000.
Yeah, well, I'm sure yours is bigger.
Mm-hmm.
All right. Need to take 5 minutes, come back.
So there's no free ventilators you can get?
Free? No.
I mean, we should be able to sign up for one.
You want me to say or not?